Welcome to We Chats, where we bring the diabetes experts to you. My name is Will, and I'm a diabetes specialist dietitian and co-founder of We Nutrition. And here at We Chats, we love having relaxed and fun conversations combining diabetes research, the experience of people living with diabetes, and the expertise of the professionals working in diabetes. Welcome to this episode where we're chatting about not just a label, the fertility first conversation we're not having about diabetes. And I'm super excited this evening because we're joined by a person who I consider a leader in this area of diabetes and an area in dietetics, a leader in dietetics as well. Welcome to Anita Beckwith, who is a clinical lead dietitian and a specialist in fertility, women's health, and diabetes. Anita, welcome and thank you for joining WeChats.
Thanks so much. Thank you for having me, Will. It's nice to be here.
Oh, very excited to have you here. And just to give people a little bit of background, you and I sort of have worked together previously,
Hmm.
and Anita knows if you're watching this on YouTube, Anita knows that I love a shoulder shimmy when I'm excited. So if you are watching this video and I'm shimmying, it's because I'm comfortable shimmying in my excitement. Um, so, Anita, for people who are meeting you for the first time right now, can you please tell us a little bit about yourself and how you came to be in this area, please?
Yeah, lovely. Thank you. Thank you, Will. That's a great introduction. Yeah, I've been a dietitian. I graduated actually in 2000, so a long time now. And most of that time I've worked in diabetes and a lot of that time in the London Teaching Hospital I'm still working at now. And through that time, really, so very much so that in diabetes, I'm particularly working with, well, there's a great scope of the practice that I work in is with people, particularly with type 1 diabetes, particularly with technologies and education. But certainly, there are also people with type 2 and gestational diabetes that we certainly see within our workload. But because of that acute setting, many of these individuals have type 1. So that's a really starting point because actually that means that we have the absolute privilege, I feel, of meeting people. And I certainly have those people in clinic when I was covering pediatric diabetes, where I've seen them from their diagnosis through, to their school, through college, through university, through first boyfriend, girlfriend, breakup, makeup, marriage, and then going on to having a family. So I've really seen that through my experience of seeing the changes and shifts that are needed, and sometimes that haven't always been acknowledged really in our care or perhaps at the forefront. I know particularly women's health at the moment is much more at the forefront and recognized, but perhaps we notice things, or we were having those conversations with these individuals where they're having a long-term condition on a day-to-day. We're seeing the differences and adjusting and manipulating things around what they're wanting to achieve in their lives, really. And we've been able to do that. So I think one part was working with type 1 people, particularly through their lifetime, is how I got there. But also that there was a shift a while ago into sort of looking more at preconception services in diabetes in the UK. And it was always something that was actually something I really wanted to, but I have my fingers in a few pies always, and I had them in far too many pies at the time. So I had to reduce some of the things I was doing before I could really focus on this area. And actually, and one of those points was that you were seeing that actually you had this time with people and you could perhaps support, you were always able to support and adjust things, but actually there were gaps in what we were able to do. And particularly for us as dietitians, we were not always the core team of that, but you could see how powerful nutrition was within that scope as well. So we'd often be very much part of the team when somebody was pregnant and beyond, but actually thinking how powerful it is, thinking of the programming and support that you can give to somebody prior to actually falling pregnant. So that was one reason that it really sort of drew me in. And as services became more focused on preconception within my London teaching hospital, I took on one of the roles of one of the nurses when she left, and that sort of broadened my scope within that way. Personally, as well, in my business side of things, I trained myself as a fertility specialist. So I did that separately. with an organisation called Early Life Nutrition Alliance, which are she's the OG, basically, Melanie McGrice of fertility dietetics. And was able and have had the privilege still working with them to be able to learn that scope from the experts and grow. And I think, one of the things, I'm sure you see that in clinic as well, is that we are seeing women who are and men, but because the clinics are particularly focused on women, I'm not excluding men from this at all, but we are seeing women who are older in the general population who wanted to start families. And that's not because always particularly absolutely by choice, but there's numerous reasons why we're seeing that. And also, as we know, and we see it reported lots, there's lots of reports recently in the last couple of weeks talking about the fertility rate declining. So again, I was seeing this gap where we were seeing women who were wanting to start families or have a number of children and were at this sort of point of trying to manage all of this with the amount of time they had in terms of fertility to then plan and balance this all through their lives. So that was a really big thing that I'd noticed for a while and then was able to get my teeth into a little bit more recently. And that's really been something that's really ignited my private practice, and part of my private practice where I really specialised in that area. So I'm able to put my sort of two expertise together and bring them together in that way. So I think that's a really key thing. I've got to say another reason is because I went to an all-girls school and there was 8 of us at I was 8 of us at school. And when I think about probably the thing that was the cure for all menstrual pain was just go swimming more laps, which was pretty much all we were ever told. Do more sport.
No.
Yeah, do more sports and you'll be fine. So I think also of us as a group of 8 who've gone through different experiences, and that may not be just for planning a family, but just in terms of reproductive health, we've all got different stories, and just how important I think it is now that the message is clear. Well, we really, the focus for us is when we were growing up was not to get pregnant, because if you even breathed near anyone of the opposite sex, that would happen. Whereas now we really understand that there are more challenges and there are difficulties. One of the things when we talk about fertility rates, it isn't specifically saying that fertility in general, the way they measure it is actually how many children a woman is having within their lifespan or in a time frame or in a year. So that average has reduced. That's what they actually measure when they're doing that. And obviously one of the factors is actually, having a real focus on career and life, and everything's so expensive that actually it's very difficult to balance where the right time to be able to do that is. So that can be difficult. So those were my real triggers. And then as I learned more about fertility dietetics, it was actually about epigenetic programming as well, which to me is just absolutely fascinating. So that's not saying how genes express themselves. You can't change that. You can't change the genetic makeup, of genes, but you can change, how they express themselves. So and diet and lifestyle, this is our place, really can have an impact on the epigenetic programming of a child through their life and through their adulthood. So that's actually so powerful that you can think from preconception stages, you can really support the health of that individual through them as an adult. That's just absolutely incredible and so powerful for us. So they're really my triggers. Long answer, sorry, but I have 3 big reasons.
No, I love that. I love that. And I think, this is part of the reason why I'm so excited to share this time with you, because I know that you have such a broad range of experience and expertise and knowledge. And, I remember when we first met, I was just in awe of how much you're able to do. I'm thinking Anita's got extra days in the week, but it's so, you mentioned privilege a couple of times of working with people. And it really is a privilege that you're here to share this with us. So if anyone is, listening to this on a podcast or watching this on YouTube, I just want to sort of highlight, it's amazing. And the fact that, it sounds like you're recognizing that change in the professional culture of preconception as well, the power that is there, dietitians taking, there's that shift in dietitians being more prominent and leading and having those extended scopes of practice. You mentioned taking on some of the nurses' responsibility, but also the cultural shift that, I'm sure we see, but also we're very much part of that change in, maybe having children later. There's the career. You mentioned, the cost of living, the cost of raising children. It's shifted monumentally over the past decade, past couple of decades. Um, and there was something that you mentioned there that again, we're going off on a tangent here, so I hope that's okay. But you mentioned epigenetics.
Mm.
And can you just break that down for someone who has never heard that word before, please?
So basically, it's literally the way that so as I said, it's not the way that the genes are actually made up, but the way that your genes can actually express themselves. So in terms of you can support the way by your diet, by your lifestyle, in terms of that way of programming, therefore, your health. So in healthful behaviors through from, and that's literally from preconception or before even planning that. So the when so if I look at say a woman's egg and the formation of a woman's egg, it takes about 12.
Mm,
We know that a woman's born with all the eggs that they have, but in terms
mhm,
of quality, particularly, we can adopt and adjust that. And we can make a change to that, particularly in the last 3 months, where they're particularly affected by external factors like diet and lifestyle and other exposures. But the actual process of follicular genesis, which is what that's called, is about the actual process of that's about 12 months. But all through that time, particularly at that last 3 months, which is where often, if you see fertility plans, they'll often talk about that sort of 90 days type factor. You can really make an impact into, therefore, that programming. And you'll often hear of something called the first 1,000 days. So I look at it as like the first 1,000 days plus at least 90 days plus potentially a bit more than that. Because the first 1,000 days are from the time a child is conceived to their
mm,
second birthday, and all of that time the nutrition that the child receives, that whether that's whilst a woman is pregnant or through their childhood to the age of 2, is actually programming their health for later in life. So it's a massive impact when we think about the chronic conditions that people do now have, the rise in things like type 2 diabetes.
mm,
There is an impact in actually how important our nutrition is, which sometimes I feel, and I don't know how you feel about this, but sometimes
mm,
because we're so lucky, particularly in the countries we're living in,
mm,
and that we have a certain choice. I know things are getting way more expensive, but we have a
mm,
choice of foods that we're able to actually have within our diets on a day to day to then support not only, and we always think of the short term. So often when I work with people, certainly they're looking for the positive pregnancy test, and then it'll be on to having the healthy pregnancy and the healthy baby. But actually, there's this massive impact that you're having through that time of the
mm.
health of the adult later in their life, which is just incredible to me. So looking at the whole picture of chronic illness and disease in general that we know is escalating in numbers, particularly, for different reasons in developed and developing countries, it's pretty powerful, isn't it, that we can be part of that.
Yeah, it blows my mind because, we're talking about diabetes and pregnancy and fertility, but
Mm,
actually almost linking to adult health and child health and future health. It's insane. It blows
mm,
my mind. So,
absolutely.
if we think about, you talk there about the 1,000 days,
Mm,
and from I'm nowhere near this experience, but like from my experience with services and preconception in diabetes, the common thing that is said by the team is, we kind of want to start planning pregnancy a year before conception. In
mhm.
an ideal scenario, I don't know if it ever happens. Quite a lot of the time we just get a phone call and it's saying, oh, I'm pregnant, congratulations. Okay, let's get to antenatal clinic.
Mm.
Um, what how does that match with the 1,000 days? What are your thoughts on this? The window or the windows that we're looking at?
Mm, mm. So we always look at that preconception period of a window of opportunity. So that can, as we know, it can support conception rates, reduce miscarriage rates, and support the whole of pregnancy and beyond. So we do think, I think the question to always having people within in clinic is, are you are you thinking of wanting to conceive in the next 12 months? And that would straight away be a referral into a diabetes preconception clinic. And then I guess when we're looking at diabetes specifically in those clinics, those clinics are glucose centric. So we're going to be looking much more at what a glucose level is. And sometimes I've found, and I don't know if you found this, that sometimes I'll be having conversations with people, and I think there's a little bit of a muddle with what a fertility clinic will do and what a diabetes preconception clinic will do, or that there'll be an automatic sort of like a cross cover sort of way of working sometimes within things that we're not able to cover within that. And that's an interesting thing as a dietitian working in, because obviously you have boundaries of practice, and I've certainly discussed this with my team, because the scope of practice within my role within there is very much as a diabetes dietitian. So there'll be certain aspects where I won't, there's boundaries that I have to have because of what actually is being covered within the service for that. And because I have a specialist interest in that, it's not expected of someone else to come into that role, and it's about the role rather than the person. And we always have to be careful with that. But so there is some, I think there can be some difficulty sometimes, or some areas where either there's an expectation that we're going to do more, or for myself, where perhaps colleagues sometimes might feel that I could do a certain amount more, but we've got to think where our role is within that. So personally for me, that window of opportunity is about glucose. It's also about supporting nutrition longer term and thinking about the things I've talked about, as you say, with the first 1,000 days, and that's certainly supportive. I think where it becomes particularly difficult, I think, as dietitians, is where this is an area, where marketing in supplements is a massive industry. And unfortunately, many people, as we know, can be exploited in very expensive regimes that they really don't need. And this is a very vulnerable group of people. So particularly for people, because when we think about preconception is about pregnancy planning. That isn't particularly saying that these people have been trying to conceive for a period of time and haven't been able to. Whereas a person going to a fertility clinic will have been trying for 6-12 months, depending on their age at least, before then having that referral, whether it's via the NHS or privately. So there's scope with where that balance is between what we are able to do within that, or what our expectations is. So I find that tricky. But the window of opportunity in terms of supporting general nutrition, so the particular diet that is particularly supportive for fertility, is the Mediterranean dietary pattern. It's nothing particularly new that we've certainly heard of, but certainly there's a lot of support you can give somebody to fine-tuning what they are able to do, and certainly in supporting people who are particularly following, say, vegan or vegetarian diets and things like this, that we can certainly support more than looking at glucose and carb counting. So I certainly see that part of a role. But there's the issue, though, with coming to a diabetes preconception clinic is where diabetes becomes the label that the person has. So, and I'm thinking even today in clinic, so I ran diabetes preconception clinic this morning, and I had a lady who was saying her mid-30s, who was feeling, you could see with her body, it was a virtual appointment, you could see her body language, you could see her shoulders, you could see she was carrying some weight on her. And they'd been trying to conceive for over a couple of years. Naturally, they're waiting for a referral from their GP to a clinic. And she was taking on very much the burden of why things hadn't happened. But within that, I felt my role was enough to, and this is something I certainly do, is roadmap people to where they want to be. And I don't know if you found this, that sometimes people will come to clinic and it's actually, you can sort of be in limbo in the fertility world of trying for something and actually going to appointments and what's actually changing or what needs to happen. So what I really like to do with people is roadmap that and think, because some people are thinking, oh, well, actually, my plans have slightly changed now. But if you're thinking, okay, what do you need to hit in that year to get to that point where you want to conceive? Because for a lot of people, as we know, depending where their blood glucose levels are, they need at least 6 months, if not a year, to optimize their blood glucose. So the window of opportunity for us also is then optimizing their nutrition alongside it. And the shame with that label is that sometimes it can almost be like two separate things. And
mm,
unfortunately, somebody could spend a lot of time going to their glucose where they could have been looking at other aspects of their diet as well. And I'd say
mm,
the other big thing about the label is that there are numerous other reproductive conditions that somebody may have. We know that things
mm.
like PCOS are more common in women with type 1 and type 2 diabetes. So there's also a thought of, how, what we're looking at in terms of a broader picture of understanding that. Not that we're going to manage that because that isn't within our scope, but it's much more about identifying and signposting, which is something I'm quite keen to look at and focus on.
And it almost sounds, and please correct me if I'm wrong, I don't know if this is the
Mhm.
right word to use, but it's almost like an advocacy for that person. It's seeing them as an individual with diabetes, but then without diabetes as well. What do you need on this journey? What does this look like? Because, health services are really tricky to navigate. Even as a healthcare professional working in healthcare services, sometimes I struggle to find my way. So road mapping sounds like a really key feature, which I can imagine would, you know, if I knew what lay ahead, I would feel less anxious. I'd worry less, and I think that's beneficial for anybody.
Yeah, yeah,
Um,
and and that factor of, sorry, when I was saying about the lady in clinic today, and I've seen it with other people, is that actually their diabetes, as I say, is one factor, and also
mm,
yes, there can be other reasons. So this lady had type 1 diabetes and she had celiac, so she was definite that this was the reason that nothing had happened. But actually, they were both being well, managed. She was really working hard, and she was reaching, optimal levels for her glucose. So actually, when you're looking at that, it's actually, me discussing with her, there are many reasons. Sometimes we, when you work with fertility clinics, you can't always absolutely work out why, but actually building the pieces together. And sometimes you can see, and a big factor with that doesn't happen within diabetes preconception clinics because it's female patients that we're seeing. There's a male
mm,
factor. So because that woman has diabetes doesn't mean her partner, whether they have diabetes or not or whatever, that also supporting and checking their fertility is really important. And that often also doesn't go in line. So that's certainly things that I make sure that we're making sure that the conversation is timely,
mm,
so that they can broach that conversation or have that conversation or encourage that conversation. I certainly encourage partners to come, so that sometimes that can be there can be some, it can be a difficult conversation. So having both people together to support each other if they can be able to attend together is really important, I think, as well.
yeah. If I think back to we run where I work, we run a monthly preconception clinic, and I think back to, the 12 people that came to the clinic, 90% came alone. And I think, you're saying this, it's a joint venture, it's together, and I'm nodding, but then I'm thinking the reality, and I'm like, hold on, I'm not seeing that,
Mm.
and that's crazy.
And
Um,
it's difficult because obviously it's time and away from work and managing things. I mean, sometimes even having a video call or someone be able to join for at least 10 minutes of it so you can, you can meet them at least and introduce yourself and be part of that. Um, but when you think, when I think of the patients I see who have diabetes and they're carrying a lot of weight of that responsibility of everything's falling on them. And this lady particularly was just very interesting today, saying that she really felt everything was about her. So it was her fault. And so there's a lot of shame and
mm,
guilt into that. She described it as, I should be able to have, there is a weight that for both men and women, that there's sort of a very it almost, in a sense, it sounds outdated that we'd even think this way, but it absolutely is still there. That the reason we're on this earth is, when people look at it in a very that simple way of, okay, to be able to create more of us, and I'm not able to do that, then I feel I'm less of. These are the kinds of things that she was expressing. These are the kinds of things I've heard, and whether people have diabetes or not, or people can have that feeling. They may not say it out loud, but they may have that feeling of. In whichever way you grow a family, it doesn't have to be, whatever, but it may feel like and that is certainly not the way we're all living nowadays, but sometimes people still have that feeling within them, and she certainly felt that way
Yeah.
as a woman today. Yeah, yeah.
And you mentioned labels as well, like the label of being a person with diabetes, or some people might say, I'm a diabetic. That can quite often carry that guilt, that shame, and there's that. I completely see what you're saying in clinic. People come to preconception clinic and we focus in on the glucose. It's time in range, it's HbA1c, it's blood glucose monitoring. And sometimes that can be at the detriment of, the psychological side of it, um,
Mm,
or just seeing the whole person and anything else that might be going on, like you were mentioning with the celiac disease, or really common PCOS, or having partners in the room as well, and discussing everyone's role in the situation.
mm,
Um, and speaking there about guilt and shame, um, I don't know what you think about this, but I quite often find that because we're talking about time and range, and it is such a special journey, um, there's a real want, a real need sometimes to get things just right. And there's almost like an unspoken perfectionism that can happen. I can see you nodding.
mm,
And we know, I quite often say to myself, don't expect perfect things in an imperfect world. And that's just me reminding myself of getting through the day, let alone diabetes or fertility or pregnancy. Um, because it drives me crazy sometimes. And we know that perfectionism can lead to burnout. I was just wondering, what's your thoughts on diabetes and burnout in the
mm.
fertility journey?
Definitely, definitely. So I think we know that particularly when I look at type one diabetes, and this isn't saying for all diabetes, but I think with type one diabetes, where someone's not producing insulin,
Mm,
then where you've got that matching of carbohydrate to insulin, so you've got this sort of clear linear path of how to do that, and then there's more self-management behaviors. And I think it was Stanford University that said there's like 180 more decisions a day someone with type 1 diabetes has to make with someone that compared to somebody who doesn't have diabetes. So incredible. How much headspace is that? And then so there's all these things, and we know that diabetes is performative. I'll often talk about this at the start of like a Daphne course,
ah,
but it has a very sort of performative way, in the sense of it's, when you go to clinic, you're getting a result, aren't you? So it's like an
mm,
exam result, and it's whether you pass or fail, and that can be translated. Not that anyone may say this, and hopefully they don't say it, but we personally, I imagine I don't have diabetes. Imagine I'd be in the same. Is thinking that almost reflects I'm a good or bad, and I'll use the term diabetic.
mm,
And actually, I'll often say to people, that number is feedback, it's not failure. So that number is telling us something about your story. It's telling us a bit, it's telling us some outcome of the journey. But what we need to learn is a bit about the journey, that, a bit more about the story, and what got you there. And as we know, our thoughts and feelings affect our behaviors. And if we're thinking about those 180 extra decisions, that's a lot of decisions, and therefore that are behaviors. And sometimes we can see that people can have perfect blood glucose in numbers in terms of those downloads, and hitting the green areas, and hitting the long-term blood glucose, the HbA1c they want. But actually their journey to get there has been one of restriction, avoidance, lots and lots of things, and a lot of personal, um, you know, personal shame, guilt we described before, but
mm,
also, really being very, discipline can be a word, but often not always, but very, might be restricted. And it's just,
mm,
and it depends where we all are with whether that's actually been a joyful experience, or whether that's taken away from the aspects of life. And it's that balance. And it's a very, very tricky thing. I often say to people, there's textbook diabetes and there's your
mm,
life. And somewhere in the middle, there's a little negotiation that can work. And we know it's hard. I think we all know it's hard. Good enough is a very difficult place to be. And I'm sure you've heard this, and I certainly have from
mm,
people I've worked with, where time in range is a measure. We're aiming for to be about 70% or more, and that's the same for diabetes preconception. But I'll sometimes have people saying, "Well, what's wrong with 100%? Why I'm always going to aim for 100%? Why would you not aim for 100%? Because that's certainly the goals of it, and we know that diabetes to get to the magic middle." We know that sometimes when we tighten things up too much, then the blood glucose levels can drop more, and it is that balancing act, and that does make trying to get things as well as you can into that place very difficult. And so it's negotiating, isn't it, that sort of good enough that each person can find where they're still enjoying things in life and not feeling they're missing out.
Absolutely. And I just want to repeat what you said there because that was a golden nugget, absolute gem. So for anyone listening to Anita share this, I just want to highlight, the performative, but it's feedback, not failure. And it shares something about the journey. Um, I sometimes I just want to say to people, and this is, in diabetes, outside of diabetes, but I think it's so relevant for our conversation. Cut yourself some slack. It's what is good enough is a very individual thing. We might have our metrics and we might have our targets, but it's about you and your journey and where you are now. And sometimes it does need just a pat on the back, a recognition of a movement or movement in the journey. Just it's keeping going kind of thing.
Mm.
I don't know what would you want to say to somebody who is listening to our conversation now and they're sort of, a person with diabetes thinking about starting a family or growing their family. And, they're maybe in this, they're experiencing some perfectionism or, really, like you say, maybe restricting. Um, you know, is there anything that you'd want to say to that person?
I think the sort of things I've said, and I think normally I've found that when I'm not work out what exactly I'm going to say, but the when I start to have that conversation, you can often see, even without someone saying something back, it can often be emotional because you're giving. So I think that's the thing of giving someone space, and my biggest thing that I find I do is normalize. And so, normalizing that people don't have perfect blood glucose levels all the time. The numbers will change. We know that there are different companies and people encouraging the use of glucose sensing in people without diabetes. We don't really have the data for that. So I think that's also impacted people's feelings of these shifts in blood glucose where they're very, very normal in people without diabetes, and they're certainly normal in people with diabetes. And actually, that thing of the other thing is a sports psychology thing I often say to people is control the controllables. So where you're looking at trying to do everything, there are so many aspects of diabetes management that are out of your control. And this is the same with fertility. So where, say, maybe it's optimizing to what you can manage your, say, carb counting with your insulin and reflecting every however often that works for you, what your insulin requirements are with what you're eating and your activity. Those things are in your control. They might not be, you don't need to do it every day. You might work out a way of fitting that in. But things like how the weather affects your blood glucose. So it might have a hypo, or the bus coming early, so you have to run for it and you didn't expect to have that, spontaneous bit of activity that causes you to have a hypo. Those things aren't. And if we can try to focus on not everything, but the things you can, I'll often talk about the goal of 3. So there's 3 things on each day to try to achieve. And they might not all be diabetes related. They might be one diabetes related thing, one family thing, one work thing, or whatever. And try to just focus on where you're getting and achieving those things as opposed to everything. And so we're really, really trying to break it down, but really trying to normalize that it's not meant to be perfect. And I think the same thing looking at fertility and bringing it together is that there are certain behaviors. So we can talk about having oily fish 2 or 3 times a week, or having whole grains, lots of fruits and veggies, say, taking your folic acid. And it doesn't need to be absolutely perfect, but if you're looking at majority of the day, or 70, 80% of the time of the week, that you're managing those things, great. But also, there is so much that isn't in an individual's control of their fertility. And I'll often say to people that even with IVF, you can introduce a sperm and an egg, and they can go together, and you still may not produce a baby, even with that science. And the science is so amazing what's happened in the last like 4 or 5 decades, that there's so much that you can do, that trying to focus on that rather than the overwhelm of what you're able to. And that's what anxiety often creates, isn't it? If you try to sit in the
Mm,
now, as opposed to all the things that you feel you've done wrong, but also being overwhelmed with what could happen in the future, that's where it becomes almost paralyzing, doesn't it? So I really try to normalize, focus on small steps, and just really normalize that lots of people have had the similar feelings, and that nobody is perfect. It's very easy to say, but I mean, we've both worked with lots of people, and sometimes the annoying thing with type 1 diabetes particularly, I'll find, is that you can do one thing one day, and the next day you do the same thing, and it doesn't quite work the same. And that's a very difficult thing to accept.
mm,
But then it is trying to look at the bigger picture of those behaviors, and where you're putting those, putting your efforts into, really. Yeah.
yeah, absolutely. I quite often say to people that are newly diagnosed that you can consider diabetes somewhere between a science and an art form, and you can do everything exactly the same on day one, and do the same on day two, and the same on day three, but each day will be different in terms of glucose, where it goes, what it does. There'll be trends and patterns that we might look for, but it will be different. And I think there's some acceptance there sometimes that, like you say, don't control everything. I love that idea of three. That's a fantastic idea. So is it three goals a day, something diabetes, something personal, and
Yeah.
something?
It could be work. It could be three of anything. It depends what you're doing that day, I guess it is. So you
Mm,
might be on holiday, and you might just think it might be, nice things like have an ice cream, do that, whatever it is. But it might
mhm,
be three things where you've got lots of goals going on, and particularly
mm,
if I think particularly I use it where there's conflicting interest, if you get what I mean. So you've got lots of things to do, and it can be paralyzing, can't it? It's so overwhelming to think,
mm.
where do I start? So really trying to break down those three things. We'll work with people like we do with goal setting, and really try to focus on it being stepped, but really looking at what's the most important, and then building on those. But yeah, breaking it down to three. You don't need to do any more. You've
I
done
love
enough.
that. That's fantastic. That's fantastic. Okay, so if there's someone listening, and again, they're thinking about this journey with diabetes, with fertility, we've talked about, well, you've shared with us about epigenetics, the window, the timing, and how what happens now can really impact on the future. You've shared with us the importance of, if having both people in the room. It's not a solo journey. But just if that is part of what is happening, then having that
Mm.
happen in the room, because we know that people do grow families individually as well. You've touched on the Mediterranean diet, and we've talked about the labels within diabetes. Um, we've talked about sort of the shame, guilt, burnout, perfectionism, sort of handling that. Um, what would be, we've covered loads here. What would be, if someone with diabetes thinking about starting this journey, infertility, what would your like top three tips be? Oh, actually, before I jump into that,
Mm.
because you mentioned about road mapping the journey as well, which I
Mm.
love that.
Mm.
There are so many good things here, but are there three that stand out as like top tips or like the most? They're all important, but are there any that sort of rise to the top a little bit more?
Um, I I definitely think road mapping's a really important thing. And I know I've mentioned it, but I think it's one of the priorities is really to think so that if you have a realistic timeline of what that is,
Mm,
you can work backwards. It might not be there, but you can work backwards and work with somebody. So whether it's your blood glucose levels, whether it's thinking about fertility checks, you've got enough time within that time to go, if I was to conceive then, where where do I need to get to? Because also
mm,
you can be quite hard on yourself if you've not got that timeline in. So you could be, treading water in limbo, doing the same, and then not really realizing that that's actually affecting you from coming to the clinics, maybe talking about pregnancy when you're not really wanting to talk about it.
mm,
So I think that that's a factor that I think helps bring it more to the table, really, of being realistic about what that looks like. Sometimes people
mm,
aren't quite sure, you don't have to, but I think it can be very helpful to just be sort of honest and reflective of yourself. It might be 2 years, whatever it is, but thinking what you need to do.
mm,
In terms of my other tip is if you have naturally been trying to conceive, and that's whether it's over 12 months for couples under 35 or over 6 months, then make that GP appointment to start having other things checked as well. The diabetes preconception clinic, after a certain period of time, will ask the GP or will ask for certain other bloods, but I would start putting that next step into place if that is really something. Because if you've got that roadmap and you're looking, then you can put this in as well. You can say, okay, well, if this hasn't happened, so you've got it clearly within there. Because as we all know, time flies very, very quickly. And
mm,
before you know it, something's passed. So I think those things are really, really important. And I think that conversation as well. My other part would be to find the people that support you to give strength within that and to help you advocate. So you mentioned it, and I'm a real strong believer in that of, understanding. So whether it's, I'll often work with people, and I must admit, fertility clients are some of the absolute experts in data and research that's available. So they'll often have a research paper under their belt as well, like just carrying it into clinic and bringing it along and talking it through. But also having somebody to, when you're feeling perhaps quite vulnerable in this situation, having people around you, whether it's clinicians, whether it's friends, to talk things through, I think is really, really important. So
mm,
that you feel that you've got the strength or community within that. And obviously, there's lots of groups, as we know, that are available. Some can be helpful, some can't be. I always think you have to pick and choose the places that you get the right support from. You learn that, don't you, in life, of where
mm,
you get the people that want to give you advice all the time, the people that are there to listen. And it depends where you are with what you're wanting and who that person is. But I think finding your tribe, finding that person that's gonna be there for you as well and help you advocate and feel strong through things, I think would be my third.
Oh, I love that. I love because there's the saying it takes a village. That village is usually there beforehand, and I'm a massive believer in chosen family, the power of community, to sort of turn theory into reality, or to just give you that pat on the back to be the cheerleader to go to for those worries is so so important. But that can also include healthcare professionals. It doesn't have to be the people at home or the people at work. It's sometimes I know I've done this as a healthcare user, asking a healthcare professional to advocate for me. Um, so people do have that power, and we're both sat here talking about it as clinicians, saying we are here to do that for you.
Absolutely, absolutely. So if you have tests and no one's explained the test, if you get bloods done and someone says they're in range, but you want to actually see the numbers, because we'll often look at optimizing numbers as opposed to them being within range. It's things like this, and sometimes you need someone else to support you to find that strength to be able to get the things that you have the absolute right to have and deserve.
Absolutely, and I guess we both work in the NHS, and we know there are constraints, but sometimes it might be asking for that extra, rather than it being a standard appointment, it's seeing that person and they might say, actually, I need more. I need a phone call, or I need a video call, or I need extra appointment. I just need something to touch base. We
Mm,
kind of expect that, you know.
mm.
So anyone's listening to this, please ask. We're expecting that conversation. Please ask. Oh, fantastic. So I've written down here. I'm making notes as we go through. Roadmap, timeline. Have that realistic expectation about what is happening, and potentially share that with someone with experience. It might be the preconception clinic, or it might be, you mentioned the GP check-in as well at a
Mm,
certain time, because yes, we might be looking at diabetes, but there's so much more going on. Um, it just reminded me of something. I think sometimes there is a tendency, or there can be that default setting to sort of say, oh, it's diabetes. And it's not always diabetes.
mm, hmm.
Would you
For
agree with
sure.
that?
Absolutely, for sure. Yeah. Yeah, for sure.
Um, and then, as you mentioned, finding your tribe, finding the community to support. Fantastic. Oh, excellent. Anita, thank
Hmm.
you so, so much for this. If people want to find more, they want more of you, where
Hmm.
can they find you, please?
The best place is social media. So I've got two Instagram accounts. One is at fertility.hormone.dietitian, and the other is more of my diabetes and sort of dietetic profession type account, which is at Anita B_RD.
Excellent. Fantastic. So Instagram is your place.
Yes, definitely, definitely.
Fantastic. Excellent. Thank you so much. Thank you for sharing your time with us, your expertise, your knowledge, and just having this lovely chat. Thank you.
Thanks for having me, Will. Thank you.